Hello friends, today we'll be discussing about cystic disease of kidney. So before starting, I would like to thank Chandana Shri Ma'am for sharing these wonderful notes with us. These are very helpful for quick revision, and the link for the notes is given in the description below. You can download it from there. So without further delay, let's get started. So cystic kidney disease could be inheritable and non-inheritable. The inheritable ones are autosomal recessive form of polycystic kidney disease, autosomal dominant form, juvenile nephronophthisis, medullary cystic kidney disease. In the non-heritable forms, we have multicystic dysplastic kidney, where we have cyst without identifiable normal renal tissue. Then medullary sponge kidney, where there is paracalicial canalicular ectasias, then some simple cyst, and acquired renal cystic disease. Now we'll understand about the multicystic and polycystic difference between multicystic and polycystic. So multicystic, where the kidney is affected, the kidney is dysplastic, resulting from the aberrant renal development. So there is defect in the development resulting in dysplastic kidney. But in polycystic kidney disease, the renal units are developed in a normal fashion. So they are normally developed and there is no dysplasia. So nephrons are normal throughout the kidney, but there will be collecting system issues. We'll see in detail. So this is the difference. Now we see about the autosomal recessive, also known as infantile PCKD, that is polycystic kidney disease. So these are generally seen in young ones, so the in utero, infancy, and up to 20 years of age group. And these have mutation in the polycystic kidney disease PKHD1 gene, that is code for fibrocystin on chromosome 6. It is associated with relatively rapid bilateral symmetric enlargement of kidney. So both the kidneys will enlarge simultaneously and rapidly, secondary to the collecting duct cyst. So there will be cyst in the collecting ducts. So due to that, it will be rapidly enlarging. Then they are associated with congenital hepatic fibrosis. So liver is also involved. And in presentation, they present with very large kidneys that could be around 20 times the normal size due to the dilated duct. And clinical features will be hypertension, renal insufficiency, and liver disease. There is no cure. Management will be through hypertension, managing hypertension, heart failure, and liver failure, and renal failure through nephrectomy and hemodialysis. Then we see the difference between recessive and dominant form of polycystic kidney disease. So recessive form, it is affected due to chromosome 6, and dominant form, it is chromosome 4 and chromosome 16. And chromosome 16, that is PKD1 gene, and chromosome 4, it is PKD2 gene. Recessive form will be having perinatal involvement up to 20 years, whereas dominant form will be having 4th to 5th decade involvement. Recessive form will have symmetric enlargement and dominant form will have asymmetric enlargement of kidneys. Recessive form will have collecting duct ectasias, whereas dominant form will have microcyst and macrocyst. Recessive form will have hepatic fibrosis, dominant form will have hepatic cysts. Then there are some other disorders in the dominant form like the Berry aneurysm, mitral valve prolapse, colonic diverticulars, cyst in the liver, pancreas, kidney, spleen, lung, and arachnoids. Now we'll be seeing the autosomal dominant PCKD in detail. So it is the most common inheritable renal disease, renal cystic disease, and associated in 1 in 400 to 1000 live births. So it is common and associated with 100% penetrance along with autosomal dominance. And as we have seen, it is seen in 4th to 5th decade and associated with cyst in various organs, liver, pancreas, spleen, lungs, arachnoid. Aneurysms can be seen in the circle of Willis, that is Berry's aneurysm or aorta. Then mitral valve prolapse, colonic diverticuli. These are the other issues these patients have. Genes, as you have seen, that they have PKD1 and 2 gene defect, which normally generate polycystin 1 and 2. and due to this defect, they have abnormal gene products, proteins, resulting in inhibition of cell proliferation and ciliary dysfunction, causing cyst generation. So these cysts originate in the walls of the intact tubules, causing dilatation. Initially, there will be filling of the fluid inside the cyst, and later, when the cyst enlarge, they lose connection from the parent nephrons, causing dysfunction. Typically, symptoms will be hematuria, could be gross, microscopic, flank pain due to mass effect, bleeding into the cyst, sometimes UTI, stones, and we know that most of these stones are due to uric acid and oxalate, as in 30% cases of the ADPKD. Then hypertension, which is due to renin or stretching of the vessels, renal insufficiency, then other extrarenal manifestation causing cranial issues, cerebral issues, and these cysts cases, PCKDs, are associated with renal cell carcinoma. Now we see the evaluation. So the family history initially is very important, apart from the clinical history, which involves at least 3 generations should be taken. USG may be showing cyst, that is more than equal to 2 cysts, could be unilateral or bilateral. CT MRI for better cross-sectional imaging, and DTPA for the renal functioning can be done. Now seeing the treatment, which is directed towards reducing complication and delaying the end-stage renal disease. For that, we can use tolvaptan, which is ADH antagonist, V2 receptor antagonist. Treatment of hypertension through AC inhibitors and ARBs can be also used together sometimes, avoiding nephrotoxic drugs. Cyst decompression through USG guided aspiration or surgical deroofing. It will provide symptomatic relief in cases where the patient is having renal flank pain. Nephrectomy with transplant in patients with ESRD, end stage renal disease, and UTI management, which could be challenging. The reason behind being poor cyst penetration of the antibiotics. So that for that we can use lipophilic antibiotics, so which are the 1-fluoroquinolone like the ciproflox and the moxiflox, levoflox, other like the trimethoprim sulfamethoxazole and chloramphenicol, and treatment of the other associated condition, SH aneurysm, etc. accordingly. So this was all about cystic kidney diseases. Hope it has been understood, and please like, share and subscribe. Keep studying, keep growing, and never give up, because great things take time. Thank you. See you in next video soon.